Hello and welcome to today's topic, Ludwig's angina. Ludwig's angina is a rapidly progressive polymicrobial cellulitis of the sublingual and the submandibular spaces involving the floor of the mouth and the suprahyoid area on both sides of the neck. It is an inflammatory edema of the submandibular region and floor of the mouth, commonly due to the streptococcal infection. Manifestations: it causes diffuse swelling and brawny edema of the submandibular region. It is commonly in severely ill and in advanced malignancy, causing trismus and laryngeal edema. Cellulitis may extend into the pharyngeomaxillary space, the retropharynx, and the superior mediastinum. Commonest cause is the dental infection of the second or third molar teeth precipitated by the tooth extraction. Other causes are the submandibular adenitis, trauma, peritonsillar abscess, upper respiratory infection, interventions like the endotracheal intubations. The predisposing factors include diabetes mellitus, chemotherapy, oral cancer, alcohol, neutropenia, caries teeth, submandibular salivary gland infection, or the calculi. The microorganisms responsible are Streptococcus viridans, Staphylococcus aureus, and the anaerobes. The gram-negative organisms may also be involved. Features: fever, toxicity, diffuse swelling, dysphagia, dysphonia, trismus. Intraoral edema in the floor of the mouth is common. Brawny swelling in the region of submandibular salivary gland. Putrid halitosis, drooling of saliva and earache is seen. Septicemia, extension of sepsis into other spaces of the neck. Investigations: CT scan or MRI is useful to identify the airway block, fluid collection, and presence of gas. Ultrasound neck is the simplest method to identify. Total count, blood sugar, chest X-ray, and offered blood gas analysis in severe cases is done. Differential diagnoses are the angioneuritic edema, sublingual hematoma, sialadenitis, lymphadenitis. Laryngeal edema can occur due to the spread of inflammation to the glottis submucosa via the stylohyoid tunnel. Laryngeal edema and respiratory distress may require emergency tracheostomy to maintain the respiration. Mediastinitis due to the spread of infection into the mediastinum. Aspiration pneumonia. Septicemia, spread of infection into the parapharyngeal spaces lead to thrombosis of the internal jugular vein, which may extend above into the sigmoid sinus, which may become fatal. Mortality is less than 5%, unlike the olden days. Treatment: antibiotics through intravenous route like the penicillins, piperacillin, tazobactam, clindamycin, metronidazole should be started. If the patient is in respiratory distress, tracheostomy is required as a life-saving procedure. Whenever distress is severe, surgical compression is required. Decompression of the submandibular region is done by making a deep incision extending into the deep fascia and also cutting both the mylohyoid muscles. Either it is left open or delayed suturing is done, or it is loosely sutured until edema and sepsis subsides, and later secondary suturing can be done. Initial steroid therapy with dexamethasone may be beneficial and is often used. To conclude, an empty lantern produces no light. Self-care is the fuel that allows your light to shine brightly. Thank you.